We are going to continue our discussion about chest injuries with an example of an open chest injury. This open chest injury causes the lung to shift away from the side that the injury is on. So if we draw our ribs here, and I'm only going to draw the ribs because I don't really care about the arms. We draw our ribs, and you know we've got lungs underneath them, right? We're going to pretend that's a lung. We have an injury to the chest wall, and that injury causes a hole into the lung. Now, that hole that has caused our open chest wound, or the injury that has caused our open chest wound, can cause air to collect in a couple of places. It can collect between the pleura, right? The air can collect between the pleura. And it can also collect inside the pleura against the lungs. Okay? Either way, the problem with this is that when that air starts to collect inside the chest wall or inside the pleural space, that air creates a bubble in here. And as you know, when air comes in, the bubble gets larger and larger and larger. So it starts pushing the lung out of the way. And as the lung gets pushed out of the way, it pushes up against the heart. That's what causes this obstructive shock. So the lung pushes up against the heart, which is located in the mediastinum. Okay? So the lung's pushed over, we've got this sucking chest wound, and it's called sucking because you can hear it. When the person breathes, you can hear the air getting pulled in through that hole. Remember, it's negative pressure that's causing that air to come in, right? So as the diaphragm lowers and your person's trying to breathe, the air that would normally be coming in through their mouth is going to come in through that open hole. There's not a ton of things that we can do to treat this. I mean, there are a couple. We're going to learn about them. But what this person needs is for that air to be pulled out of that lung. We can get them to the hospital. We can do the best we can to treat them between now and then. But what they need is for that air to be pulled out of that lung. And we can't do that. Okay? So this hole that we have right here, there's really basically 3 tools that we have in our toolbox to treat this. 4. Okay? Do you guys have any idea what they are?
MRE wrapper with duct tape.
We can wrap it with duct tape.
Occlusive dressing.
An occlusive dressing. And what is an occlusive dressing?
Sticky that doesn't it's sealed on all 4 sides.
Okay. It can seal on all 4 sides.
Plastic.
Pardon?
Is it made of plastic or?
There's probably petrolatum or Vaseline on there too.
Use anything,
You can make an occlusive dressing if you don't have any, but
MRE wrapper.
this
Playing card.
is an occlusive dressing. Now, if we're pretending that we're using this occlusive dressing, we're not going to pull this all the way off if we can help it. Okay? What I am going to do is I'm going to draw it on the board, and then some of you can do it to each other. But we're going to place the occlusive dressing over the top of the injury. And we want to tape 3 sides. Why do we want to leave a relief valve there?
So that when he exhales and squeezes the air out, it'll bleed out. But then when he goes to take a breath, it'll close.
Yeah, it works like a one-way valve, right? So we're going to tape this on, and you guys can check this out, because this has got petroleum in it. And so it's kind of sticky. So air should come out. Air's going to come out, but it's not going to come in. It's like the one-way valve in our non-rebreather mask, right? Yeah, go ahead.
Do we?
Rigid.
It is.
Maybe it's old.
It's a little sticky.
It's a little
It's
sticky.
greasy.
Yeah. I don't know what the expiration date is on this. Ha! They expired in 2013. Maybe that's why. 4 years ago is when they expired.
Works for
So
Sam.
we're doing all sorts of good stuff to help me find what I need. I need saline and occlusive dressings. That's awesome because my kids are going to need them soon. So if you can imagine how this works on a person. Want to lift your shirt up and be a model? No?
No, I do not.
Someone else want to volunteer? No?
Maybe if it was summer.
I don't care. take one for the team and all that crap.
All right, so we're going to pretend that the wound on his chest is in the same place as the wound on our drawing right there, okay? So we're going to take our occlusive dressing, just the way it is, and we're just going to slap it right on here. And by slap, yeah, it's cold, sorry. By slap, I mean place it gently because we don't really want to hurt him, right?
Yep.
Now, if I had been smart and thinking, I would have cut my tape ahead of time. Because I wasn't smart and thinking, I didn't cut my tape ahead of time. So now my patient's holding that there while I take care of the tape. It doesn't really matter what side I leave open. Like I could leave one of the corners open, I could leave a short side open, but I like the idea of leaving a short side open, so I'll probably do that. So I only really need 3 pieces of tape, and we're going to tape it, I'm going to tape the long sides first, and then I'm going to tape the short side. So I'm just going to go right here, and across the top. Okay, because we've got an injury right here. I'm going to go across the bottom. Sorry for the hair.
It's all good.
And then depending on which side my injury is closest to, that's probably the side that I'm not going to tape. So if we say that the injury is right here, I'm going to leave this side open. So I'm going to tape the back. Now, there's no air getting in from those sides. There's no air getting in from this side because it's a one-way valve. Okay, but we're going to get air pushed out. And that's okay because we don't want that buildup of air in there. Make sense? Okay, thanks.
You're welcome.
Now, the other tool that we have in our toolbox to take care of a pneumothorax or tension pneumothorax is positive pressure ventilation. How do we supply positive pressure ventilation to our patient?
Bag valve mask.
Bag valve mask. Even if your patient is conscious, a bag valve mask is going to be helpful. So this is for a sucking chest wound. We're going to use an occlusive dressing. And positive pressure ventilation. What's the difference between positive pressure and negative pressure?
One you're forcing
pushing
air
air
in, the other one sucking air in.
Yeah, so what is the benefit to your patient going to be if we're forcing air into their lungs?
You're inflating that collapsed lung, therefore pushing the air out, and your one-way valve will prevent it from. So you're making progress with every breath, every compression.
Correct. Now the downside is that if we do it too hard, we can cause more damage to the lung than we are causing help or providing help. So we have to be careful when we're providing positive pressure ventilation. But positive pressure ventilation is the other tool that we have in our toolbox. What's the third one? And it's one that we have available to us no matter who our patient is or no matter what they are.
Transport.
Transport. Yeah, we always have that tool available to us. Transport. Now, if you're supplying positive pressure ventilation to your patient, you better be using oxygen. That should go without saying. It should go without saying, but I'm going to write it down there anyway. Okay? So, for a sucking chest wound, to treat a sucking chest wound, we use an occlusive dressing, positive pressure ventilation with oxygen at least 15 liters per minute, maybe up to 25 liters per minute. Okay? And then we're going to transport as fast as possible. We can't do anything to fix this. We can stave off the symptoms, we can help a little bit, but we cannot fix this. So our goal in this situation is to get that person to definitive care as quickly as we can. Okay? All right. A flail chest or a flail segment is considered a closed chest wound. What is it?
A piece of the chest is broken, so like your ribs will break into like a chunk.
Your ribs will break into like a chunk. So if we look at our chest wall here, I'm going to go with our ribs again. A flail segment or flail chest occurs when 2 or more ribs break in 2 or more places. So let's say, I'm going to put a couple extra ribs in here because it'll be easier to draw that way. So let's say that our patient got hit in the side with a football helmet. Fairly common, right? If you're playing football, it's fairly common for you to get hit in the side. You could potentially break some ribs. So let's say they got hit in the side with a football helmet, and because of that, we've got a fracture Okay, so these 3 ribs are no longer connected to the chest wall. What happens? Can you see a difference?
they'll move up and down.
And like go in
It's
and
called
out.
paradoxical motion.
It's called paradoxical motion. And what is it, Corey?
The segment will like go in and out with the opposite of the like what you think would be happening.
Right. So the segment of the chest wall will go in and out opposite of the person's exhalation or inhalation. So if they inhale, remember that negative pressure is causing air to rush in through the windpipe, but it's also causing, that negative pressure is causing this piece of the flail chest to suck in as well. Yeah? Paradoxical motion it's shocking and cool when you see it in the field. And it's odd, but it's kind of cool. How do you treat that? What does your book tell you to do to treat it?
Maintain airway, provide respiratory support if necessary, give supplemental oxygen, and positive pressure ventilation with a bag valve mask. In the past, they splinted it with bulky dressing.
How did they splint it?
With bulky dressing,
With bulky dressing.
it's no longer recommended.
Why not?
Positive pressure is now preferred. I don't know.
So you bag them.
You bag them. Why did they stop using bulky dressings?
Then it just press it
Probably
in.
because to put it on there, you had to further restrict the person's chest cavity.
Depends on how you apply the bulky dressing, but that might be part of it. But you can't really splint a bone from one side. If you apply a bulky dressing to the outside of the chest wall, because they're having paradoxical motion, you can't splint the inside. They're still going to be having paradoxical motion, you're just not going to be able to see it. Do you want to be able to see it? Why?
See if it's getting worse or causing damage elsewhere.
It could be causing extra damage. It could start causing superficial damage. Why else do you want to be able to see it?
That way you know where the injury site is, so when you pass it along, you can say that's what it is.
It's right here, poke, poke, poke.
I would imagine that those bones were probably sharp, and as they go back and forth, they may actually start to cut through the chest wall. And you need to know about that because that could develop into a sucking chest wound.
It could develop into a sucking chest wound. But more importantly, if you are providing positive pressure ventilation, and your positive pressure ventilation is working, you should see a decrease in paradoxical motion. Why?
Because there shouldn't be as much space for the thing to move.
Well, once again, you're inflating that lung.
You're pushing air in instead of sucking air in. So that negative pressure that was causing the ribs to collapse in is no longer occurring because there's no negative pressure there. So that the movement of the ribs into the lungs is not happening because you're providing positive pressure instead of counting on negative pressure for your patient to get respirations. Now, you're going to run across people who still believe that this is the answer. Because you're going to run across people who still believe that this is the answer, I want you, when it comes time for your skill, because in your National Registry Skills exam, you are likely to see one of 2 scenarios. One of the scenarios, you'll have a sucking chest wound. The other scenario, you will have a flail chest. So if you come across the flail chest, I want you to tell your evaluator. You guys need to remember this because I want you to tell your evaluator. If I'd been trained 5 years ago, I would have put a bulky dressing on this. But because I was trained this year, and recent literature and EMS research suggests that is no longer appropriate, I'm going to provide positive pressure ventilation and transport my patient as quickly as possible. There's no way for me to know if your evaluator is one of the ones who believe that a bulky dressing is necessary or not. If your evaluator is one of the ones who believes that a bulky dressing is necessary and you fail to put it on there and don't address that with them, you will fail that station because it's an inappropriate or what's the phrase?
Dangerous. Or
Inappropriate or dangerous intervention. Or they will mark you for not treating the life threat. So even though I collect the evaluators and I bring them here, I can't go to each one of them and say, I'm thinking about letting you assess trauma. Do you believe in bulky dressings or not? So you guys need to be prepared with that in your mind. If your patient presents with a flail chest, you need to be prepared to tell the evaluator, you've considered a bulky dressing, it's no longer recommended, EMS research has shown that it does not help, and so you are going to provide positive pressure ventilation and transport your patient as quickly as possible. Which means our other tool is transport. Now, do we know the difference between a sucking chest wound and a flail chest? What's the difference?
one's open, one's closed.
One's open and one's closed. What if the flail chest has a cut over the top of it?
Has to be in the chest wall.
Okay, it's still considered a closed wound, right? If you say something like you're putting an occlusive dressing on a flail chest or a bulky dressing, particularly a bulky dressing on a sucking chest wound, this also, mixing these two up, is also considered a dangerous or inappropriate intervention. Okay? When we start seeing these things in our patients' level of consciousness is likely to change. It's likely to decrease. That's expected. They've got a wound to their chest that's causing them difficulty breathing. Their respiratory rate is probably going to go up. Their lungs can't expand as far as they're used to, so they have to take smaller breaths to have the appropriate tidal volume. Smaller breaths to make up the appropriate minute volume. So their tidal volume will be decreased, but they'll have a higher number of breaths to make up that minute volume. Okay? At some point in this process, this whole sucking chest wound, shifting lung, crushing heart process, you're going to stop hearing lung sounds from the side that has a tension pneumothorax on it. Okay. A tension pneumothorax in and of itself does not have to be an open chest wound. A pneumothorax can come from a simple pneumothorax, or a spontaneous pneumothorax, which is what happens when tall, thin men cough too hard. Their lung separates from their chest wall. It's spontaneous, and at that point, it's considered a simple pneumothorax because their lung hasn't moved. Their lung hasn't collapsed yet. When their lung starts collapsing and moving the structures off to the side, that's when it becomes a tension pneumothorax. If your patient is exhibiting the signs and symptoms of a tension pneumothorax, what are you going to see?
Jugular vein dissension and tracheal deviation.
Yeah, because our lungs are shifting off to the side, our lung airway is also going to move off to the side. So instead of going straight down the midline, it's going to kind of shift off to the side a little bit. And why are we going to have JVD?
Because the heart's going to start getting obstructed, so then it's going to have a hard time pumping blood throughout the head, I guess. I don't know.
You were on the right track until you got to the pumping part. Because the lungs are obstructing the heart, it can't receive as much blood. So the veins are the vessels that return blood to the heart, right? When it can't receive as much blood, the ventricle can't expand as much as it wants to receive enough blood. We start getting that backed up into our jugular veins, and that's why we see JVD. Okay, so you were on the right track. Okay, flail chest. All right, what are we going to do for a cardiac tamponade?
Transport.
Transport.
Get a giant
Requires
needle.
an operator room.
Yeah, we're going to transport. Provide oxygen. All of these, every single one of these, we need to provide oxygen. Be prepared to provide positive pressure ventilation to this patient as well. He's got a problem with his heart. What's going to happen to his heart? He may lose consciousness. His heart might stop beating because he's got blood collecting in his myocardium. Not myocardium, pericardium. Myocardium is the heart muscle. that sac, it's not flexible. It's very much, I mean, it's obviously it's not a bone, but it's very much like your brain. It doesn't move when swelling happens. It doesn't move when there's a collection of fluid there. So the only movement that can happen is movement within the muscle itself, within the myocardium itself. So the myocardium starts to not have enough space to expand. We may also see JVD here, for the same reason that we might see JVD over here. The heart can't expand enough to accept all the blood that's coming back to it. So we get backup here. We're probably also going to be having backup in the rest of the body, right? In our inferior vena cava. We're not going to see it because there's so much body here. And your veins are not particularly close to the surface in the rest of your body. I mean, they are in your extremities and stuff. But in the rest of your body, they're kind of buried. So you're not really going to see that backup of fluid. Okay? Okay. Let me see if there's anything else in here. Simple, tension, open. Well, what is a hemothorax? What's a pneumothorax first?
Air.
Air. It's air in that chest wall, right? That's what pneumo means. It means air, and now a pneumothorax is air in the chest wall or in the thoracic cavity. So what's a hemothorax?
Blood in the lungs.
Blood. We've got blood collecting in that cavity. So you can have a pneumothorax, you can have a hemothorax, you can have a hemopneumothorax, which is a combination of blood and air. All of which you're still going to have to treat the same way. Positive pressure ventilation. If it's an open wound, you treat it with an occlusive dressing and transport your patient. Let's see what else we got. Cardiac tamponade, whale chest. Okay, so a pulmonary contusion is essentially a bruise to the lungs. And that bruise, what happens when you get a bruise? I mean, we know what causes a bruise, right? We've got some type of trauma and it breaks the blood vessels. What happens?
You get swelling and you get bleeding into those tissues.
You get swelling and you get bleeding into those tissues. If we have swelling and bleeding into our alveoli, is that going to cause us a problem? Our alveoli are teeny, teeny, tiny. The most minuscule amounts of blood and swelling can cause them to no longer function or to function inappropriately. So, a pulmonary contusion is some type of bruise into the lungs in which blood and swelling has now started collecting in the alveoli. You can really the only thing that you can do for a pulmonary contusion is to provide positive pressure ventilation. And if you can provide that positive pressure ventilation, you might be able to push some of that fluid and blood out of the way so that the air can get back into the alveoli. Sternum fracture, clavicle fracture.
Is there anything to say about how you position the patient? Is that a situation where you might not want to lay them down?
You might not want to lay them down. If they're conscious and talking to you, you might not want to lay them down because they're gonna want to be in a position of comfort. So likely they're going to be in a tripod position. However, as soon as you have to provide positive pressure ventilation to your patient, the easiest place for you to do that is on their back.
Okay.
The other one that I kind of want to talk about is commotio cordis. What is commotio cordis?
It's when you take a sharp blow to the chest and it causes cardiac arrest. Such as getting hit with a baseball.
Yeah. It's a sudden blow to the chest that occurs during a specific part of the heartbeat. And it has to occur during that specific part of the heartbeat because it interrupts the electrical signal. What is the treatment for this?
CPR.
CPR, you got a dead person in front of you. It's not necessarily a common injury, but it is one that happens. So if you get to a scene and you've been told he got hit with a ball, or he got hit with a bat, or he got hit with something in the chest and suddenly he collapsed, it's a pretty good bet that this is it. Laceration of the great vessels. When we did car accidents and we drove our cars or our chairs into each other, we did the side impact, right? In about 25% of severe side impact collisions, it can cause damage to the aorta. It can cause a laceration to the aorta. And that laceration to the aorta occurs because within the mediastinum, or the mediastinum, depending on what you want to call it, the heart exists in that little bubble. And it's got some tendons that hold it in place, but there's some room there for it to move back and forth, right? It can't move front to back, which is why we don't see as many injuries in front to back collisions, right? Or head-on collisions, we don't see as many aortic injuries, because the heart can't, it doesn't have a lot of room to move front to back, because it's trapped between your sternum and your spine. Right? But side to side, it's got some room there. Let's look at Mr. Godet here and pretend that our heart is right here. Front to back, it doesn't have a ton of room. If this metal thing wasn't here, it'd be easier for you to see. But side to side, it's got plenty of room to move. And your aorta isn't designed to stay attached if the heart's moving side to side. So in those lateral collisions, you can wind up lacerating the aorta. Laceration of the aorta is very, very, very difficult to survive. That's the largest vessel in your body, right? Laceration of any of your great vessels is difficult to survive, but particularly the aorta. Any questions? Anybody? Wasn't a 3-minute lecture.
But it's good.
Okay.